good afternoon friends. Today we are going to discuss one of the important chapters in GIT, that is on liver. Okay, we are going to discuss in liver about portal hypertension, about the infectious diseases in liver, and about the tumors. These are the three topics we are going to discuss today in liver. Okay, so before going into the depth of liver, let me discuss the basic things you should know for your exams in liver. So please remember, liver is the largest solid organ in your body. Liver is the largest solid organ in your body, and it has a hilum. This is hilum of the liver. In this hilum of liver, the posterior most structure located is what? What is the posterior most structure entering the hilum? This is portal vein. Anteriorly to the left side is hepatic artery, and to the right side is bile duct. So this is known as portal triad. What are the relation of the three structures in portal triad is posteriorly we have portal vein, anteriorly to the right we have hepatic artery, to the left we have bile duct. And let me discuss the hepatic artery alone here. This is the hepatic artery which enters the liver and divides into right and left hepatic artery, and you can see this is arising from the celiac trunk, and it gives gastroduodenal artery, and it gives right gastric artery. So the branches coming from common hepatic artery are right gastric artery and gastroduodenal artery are the two important arteries coming from common hepatic artery, and it divides into right hepatic artery and left hepatic artery. So right hepatic artery gives the branch cystic artery. So now there is a high yield MCQ for institute exams. So the arterial anatomy is highly variable. Not only the bile duct anatomy is variable, the arterial anatomy is also highly variable. Sometimes the left hepatic artery may be arising from a aberrant or abnormal. Aberrant left hepatic artery comes from where? It comes from left gastric artery. Please don't forget this point. Aberrant left hepatic artery comes from left gastric artery. Aberrant also sometimes it may be a replaced. So aberrant or replaced left hepatic artery comes from left gastric artery. Similarly, aberrant or replaced right hepatic artery comes from SMA, comes from superior mesenteric artery. So if it is aberrant or replaced right hepatic artery, it comes from SMA. And interesting point is this aberrant right hepatic artery runs posterior to portal vein. Usually portal vein is the posterior structure. If it is aberrant, it comes posterior to portal vein. Okay, it comes from posterior to portal vein. Sometimes the celiac artery is also aberrant. The cystic artery is also aberrant. It comes from GDA. Cystic artery, that is known as accessory or aberrant cystic artery, comes from GDA. So please don't forget, abnormal right hepatic artery comes from where? Abnormal left hepatic artery comes from where? Abnormal cystic artery comes from where? Please don't forget this. Abnormal origins, abnormal or replaced origins are coming from abnormal or replaced right hepatic artery comes from superior mesenteric artery. Left hepatic artery comes from right gastric artery, and cystic artery comes from gastroduodenal artery. Please don't forget these abnormal origins. This is an old Ames question. Abnormal or replaced origin of the vessels. And interesting MCQ here is the abnormal right hepatic artery coming from superior mesenteric artery runs posterior to portal vein. It runs posterior to portal vein. Please don't forget this point. It runs posterior to the portal vein. Okay. And now coming to the bile duct. This is the bile duct. You all know very well. Bile duct gets its blood supply from which artery? Can you tell me? From which artery the bile duct gets its blood supply? From the right hepatic artery. Please don't forget, this is a neat question. So there are vessels running on either side of the bile duct. For example, if this is a bile duct, the blood supply to the bile duct comes on 3 o'clock position and 9 o'clock position. It runs 3 o'clock and 9 o'clock position from right hepatic artery. It is arising from right hepatic artery at 3 o'clock and 9 o'clock position. It runs down. So the major blood supply of bile duct is from right hepatic artery by a branch from right hepatic artery running down from 3 o'clock or 9 o'clock. Similarly, from gastroduodenal artery also there will be branches running from below upwards. So another one supply is from GDA. GDA also gives branches running along the bile duct like this. GDA also gives branches running along the bile duct from below upwards. So anyhow, the bile duct has the blood vessel, bile duct, polyductal vessels run at 3 o'clock and 9 o'clock position coming from right hepatic artery. So please don't forget this point. And in liver, the major blood supply of liver, around 70 to 80% of the blood flow to the liver is through portal vein. Please don't forget this. Only 20% of the blood flow is through hepatic artery. But please don't forget, though hepatic artery is only 20%, the oxygenated blood is through this only. Oxygenated blood is through hepatic artery only. Oxygenated blood is through hepatic artery only. An interesting point, please don't forget this MCQ. If there is a tumor in the liver, this tumor receives 100% blood supply from where? Which vessel? 100% the blood supply of the tumor is from hepatic artery. So please don't forget, 100% the blood supply is from hepatic artery. So please don't forget, the 100% blood supply is from hepatic artery. So these are basic points you should not forget in liver. And from liver, the hepatic artery and portal vein divides into multiple sinusoids, and from these sinusoids the blood will drain into three veins. Right hepatic vein, middle hepatic vein, left hepatic vein, which will drain into the IVC, that is nothing but systemic circulation. From there, the blood drains into the systemic circulation like this. So this point you should not forget. They drain into the sinusoids, and from sinusoids they go to the hepatic vein, and hepatic vein to IVC. From here it reaches the heart. This point you should not forget. Okay. So whenever you start discussing about liver, usually the examiners will expect you to know about the Coinot segments. Coinot segments of liver. How many segments are there? Can you tell me? How many segments are there in liver? So please remember, there is no one liver. We have totally 8 segments of liver. So there is totally 8 segments of liver. I am going to make it very simple, nothing to mug up in this. So please remember, liver is now divided into 8 segments. The main division is by this middle hepatic vein. The middle hepatic vein is the one which is mainly dividing the liver. So middle hepatic vein corresponds to a line known as Cantel's line. The Cantel's line is the exact division of liver into right and left. So anatomy people telling that falciparum ligament into left lobe and right lobe is not the correct one. So the correct division of liver is by this line known as Cantel's line, which runs at the level of middle hepatic vein. And this is another vein, that is right hepatic vein. This is another hepatic vein, that is left hepatic vein. That is known as left hepatic vein. So please don't forget. So left hepatic vein, this is right hepatic vein dividing further the liver. So these fissures are known as major fissures: middle fissure, right fissure, left fissure. So the hepatic veins runs along the main fissures, and divide the liver. Now into how many parts we have divided the liver? Into 4 parts. So please remember 4 parts. And the Coinot segments of liver is primarily by hepatic veins and also by Not only by hepatic veins, also by portal veins. Many times this question is a controversial question. The examiners may sometimes, without knowing what is this, they will ask you Coinard segment is based on dash. So you can very well say Coinard segment is not only based on hepatic vein. Hepatic vein divides the liver into 4. Now the portal vein coming from down will divide the liver into 8. You can see now the liver is divided into 8. They divide into right and left, and now there are totally 8 segments formed. So portal vein and hepatic vein divide and form 8 segments in the liver. Okay, and Cantel's line is a line running from IVC to gallbladder fossa. It is to the gallbladder fossa, and it is also known as cholecystocaval line because it is running from gallbladder to IVC. It is also known as cholecystocaval line. Please don't forget this MCQ. So Cantel's line is nothing but cholecystocaval line. Cholecystocaval line. So now I hope you understand how the segments are divided. Now I am going to make the picture in a different way for understanding purpose. For understanding purpose, I am making this. Okay, I am understanding purpose, I am making this. So this is the middle hepatic vein, also known as Cantel's line. So now I am going to divide the liver. Cantel's line. And you all know very well, this is left hepatic vein, this is right hepatic vein, which have divided the liver into many things. And now this is right portal vein, and this is left portal vein, which is further dividing the liver. Now you are going to tell me the names of each segment. This segment is known as 2, this is 4, sorry, this is 3, this is 4A, this is 4B. So please remember, it is going in a clockwise direction, 2, 3, 4A, 4B, and coming this side, it is 5, this is 6, this is 7, this is 8. And don't worry about segment 1, it is there separately posterior. On the posterior surface of liver, we have segment 1, don't worry about it. So just remember these segments. I'm going to tell around 10 MCQs from this now. I'm going to tell 10 MCQs now. So segment 2 and 3 are known as segment 2 and 3 are seen medially. They are seen medially. Segment 2 and 3 are seen medially. And 4 and 4A and 4B are seen laterally. They are seen laterally. Okay. So now please don't forget, I am going to tell you certain points which are essential for exam. 6 and 7 are known as right posterior segments. 6 and 7 are known as right posterior segments. So let me discuss very clearly, not to get confused. Please follow this what I am telling now. Just I am going to write everything. 6 and 7 are known as what? Segment 6 and 7 are known as right posterior segments. They are known as right side, right lobe, posterior segments, 6 and 7. 5 and 8 are known as right side anterior segments. So 5 and 8 are known as right side, and you just follow this what I am writing and remember this for your exam. 5 and 8 are known as right anterior segments. If you understand this very clearly, you will not get confused in your exams. Please remember, if you understand this very clearly, you will never have any confusion. And segment 2 and 3 are present where? Segment 2 and 3 are present lateral to the, what is this ligament here? They are present lateral to the falciparum ligament. So they are present lateral to the falciparum ligament. So therefore they are known as left lateral segments. So lateral to the falciparum ligaments are known as left lateral segments. Medial to the falciparum ligaments are known as left medial segments. 4A and 4B are known as left medial segments. They are known as left medial segments. So right lobe is divided into anterior and posterior. Left lobe is divided into medial and lateral. So left lobe is divided into medial and lateral. Now this is the typical picture showing you the segmental anatomy. So because I am going to explain you questions based on this only. So please don't forget. So the segments can be divided into 8 segments, 2, 3, 4A, 4B, 5, 6, 7, 8. 2 and 3 are known as left lateral segments. 4A, 4B are known as medial segments. So right side anterior is 5 and 8, right side posterior is 6 and 7. What is the importance of each segment means? Each segment will have its own bile duct drainage, own hepatic artery flow, own portal vein flow, and own hepatic vein drainage. So each segment is a separate liver. They have all the flow, bile duct, hepatic vein, hepatic artery, portal vein. So therefore, Coinard found out each segment is a separate functioning segment of liver. Please don't forget this point. And this concept has made us do number 1, resection for liver cancers. Resection for liver cancers. Before the invention of these segments, we thought liver is only one, and if there is a metastasis in the liver, it is inoperable. Now you can do segmental resection for metastasis or for HCC also. So resection came into force only after segmental anatomy. Number 2, the most important miracle which happened only after this segmentation is liver transplantation is possible as a live donor. Living person can give liver. Living person can give liver only after this. Before that, people are thinking there are 2 kidneys, so you can give 1 kidney, and there is only 1 liver, so you cannot give liver. But after this concept, people started knowing they are having 8 segments of liver, so they can donate some segments of liver. So this concept also came into act because of this segmental anatomy. So the 2 miracles which happened after segmental anatomy is we can do resection for liver cancers and we can do liver transplantation for live donors, and also split liver transplant is possible. We can divide the liver and give to 2 persons is also possible. Split liver transplant is also possible because of knowing this segmental anatomy. So now let me tell you the MCQs asked from this. MCQs asked from segment. So please don't forget the first MCQ. Segment 1 is what? Segment 1 is separately located. It is exactly located on the IVC. Here it is located like this. It is segment 1 which is sitting on the IVC. It is sitting on the IVC. It is known as caudate lobe. The interesting point is it will not only have bile duct, not only have hepatic artery, not only have portal vein, not only have hepatic vein drainage, it also has direct drainage to IVC. Direct drainage is also available. Direct drainage to IVC is present. There is a direct drainage to IVC is present in caudate lobe. And caudate lobe is further divided into 2 segments. What are they? What are the 2 segments of caudate lobe means? There are 2 segments which are dividing in the caudate lobe. They are known as segment 9. So when I will show you this image when I am discussing the picture. Segment 9, and there is one more lobe known as spigal lobe. Caudate lobe is divided into segment 9 and spigal lobe on surgical dissection. There are 2 lobes which form the caudate lobe. So please remember, caudate lobe is located on the posterior surface. It is a separate segment, segment 1. It has direct drainage into the IVC. And please don't forget, in case of Budd-Chiari syndrome, this lobe alone is not affected. Why? Budd-Chiari syndrome is a syndrome having hepatic vein thrombosis. So even if there is hepatic vein thrombosis, caudate lobe will not be affected, and there will be caudate lobe hypertrophy. In Budd-Chiari syndrome, there will be caudate lobe hypertrophy seen. So please don't forget these points about segment 1. Segment 1, caudate lobe has a direct drainage to IVC. Therefore, it is enlarged in Budd-Chiari syndrome. Question number 1. Number 2, there is Brisbane classification of hepatectomies. Brisbane classification of hepatectomies. So what are the types of hepatectomies available according to Brisbane? So please tell me what is left hemi-hepatectomy, also known as left hepatectomy or left hemi-hepatectomy. What are the segments removed? Can you tell me? They are 2, 3, 4A, 4B. So in left hemi-hepatectomy, segment 1 is not included. Segment 1 is a separate lobe. Right hemi-hepatectomy. What are the segments removed? One of the big chapters, this liver chapter, I want you to focus more. So 5, 6, 7, 8 is removed in right hemi-hepatectomy. So now left lateral hepatectomy. What are the segments removed? Can you tell me? Left lateral hepatectomy. The question is asked in national board exams. When you resect the liver lateral to falciparum ligament, what are the segments removed? Segments are 2 and 3. Left lateral hepatectomy, the segments removed are 2 and 3. And I'm going to show you one of my recent surgeries at the end of this chapter. Right posterolateral hepatectomy. Right posterolateral hepatectomy. What are the segments removed? Can you tell me? It is, please come back to this picture. You should never forget this picture. This is a high-yield screenshot picture you should have in your mind. So right posterior segments 6 and 7 are removed is known as right posterolateral hepatectomy. Also known as right posterior hepatectomy is 6 and 7 are removed. Segments 6 and 7 are removed. Okay. And there is one procedure we discussed in gallbladder surgery. What is the name of the surgery known as radical cholecystectomy? So radical cholecystectomy, what are the segments removed? Radical cholecystectomy, the segments removed are, please come back to the picture and focus here again. So gallbladder is lying on this place. So the segments we remove in radical cholecystectomy are 5 and 4B. Please don't forget 4B and 5. 4B plus 5 will be removed in radical cholecystectomy. Central hepatectomy. Central hepatectomy. It is also done for gallbladder cancers or for intrahepatic cholangiocarcinomas. It is also known as Taj Mahal hepatectomy. Taj Mahal hepatectomy, because you are going to resect this like a Taj Mahal. You just see how I am resecting it. 5, 8 and 4B. It looks like a Taj Mahal. So this is known as central hepatectomy or Taj Mahal hepatectomy. What are the segments removed in Taj Mahal hepatectomy? 4B plus 5 plus 8 are the segments removed in Taj Mahal hepatectomy. 4B plus 5 plus 8 is removed in Taj Mahal hepatectomy. Right trisectionectomy. What are the segments removed? So I'm going very slow. Please don't forget again and again. You have to remember this by knowing the main anatomy. So right segmented is trisegmentectomy. Sectionectomy is nothing but extended right hepatectomy. That is the other name of this. Extended right hepatectomy is other name of right trisectionectomy, in which we remove the entire right lobe 5, 6, 7, 8 plus what we will remove in trisectionectomy. We will remove 4A plus 4B also. So that is known as right trisectionectomy. The right lobe we extend to the right trisectionectomy. It is usually done for hilar cholangiocarcinomas. Hilar cholangiocarcinomas type 3A we do this operation. I hope you will recall what we have discussed in gallbladder chapter. So right trisectionectomy type 3A hilar cholangiocarcinomas we do this. Similarly left trisectionectomy. Left trisectionectomy also known as extended left hepatectomy. What are the segments removed? So you can easily remember by understanding the first picture what we draw. So 2, 3, 4A, 4B plus what we will remove? This question is a repeat neat question. We will remove 5 and 8, that is known as extended left hepatectomy or left trisectionectomy. This is done for type 3B hilar cholangiocarcinomas. Type 3B hilar cholangiocarcinomas. So this and all you will understand when you go back to the bile duct chapter and see what we discussed. 3A is a hilar cancer extending towards the right ducts. 3B is a hilar cholangiocarcinoma extending to the left ducts. So if it is extending to the right ducts, we do extended right hepatectomy. And if it is to the left side, we do extended left hepatectomy. So these are all high-yield MCQs. You should never forget. Brisbane classification of hepatectomies. So left hepatectomy is 2, 3, 4A, 4B. Right hepatectomy is 5, 6, 7, 8. Left lateral hepatectomy is 2 and 3. Right posterolateral hepatectomy is 6 and 7. So radical cholecystectomy is 4B plus 5. Central hepatectomy is 4B plus 5 plus 8. It looks like a Taj Mahal, so it is known as Taj Mahal hepatectomy. So right trisectionectomy is adding with right hepatectomy 4A, 4B. Left trisectionectomy is adding 2, 3, 4A, 4B with 5 and 8. So now that is one MCQ. For pediatric live donor liver transplant, what are the segments donated by the mother or father? Pediatric live donor transplant, segments donated by father or mother is only 2 segments. What are they? Just 2 segments is enough for the baby. It is segment 2 and 3. So the segments donated by the mother or father to the baby for a pediatric live donor transplantation is 2 and 3. For adult donor transplantation, adult live donor transplantation, we need to give bigger lobes. Adult live donor transplantation, we have to select bigger lobes. Okay, we cannot give only 2 and 3. We have to give more segments. We have to give more segments like 5, 6, 7, 8, or else sometimes we can even add up 4A plus 4B also is sometimes added. So depending upon the body mass index of the recipient, we have to give adequate liver. If you don't give adequate liver for the recipient, the patient will die of many other syndromes which we will discuss in liver chapter. So please remember, pediatric is a repeat question. What are the segments given by the mother or father to the baby? Segment 2 and 3 is given by the mother to the baby. Okay, please don't forget these points. This is Brisbane terminology of hepatectomies. These are the Brisbane terminology of hepatectomies. I hope you are clear. Are you clear with this hepatectomies? This one picture is very important to understand the entire chapter of hepatectomy. So this is Coinot segments. You just think how this segmentation has made a miracle. Now we can, if there is a tumor in this segment like 7, I can remove only segment 7. If there is a segment in 2 and 3, I can remove only 2 and 3. Like that, many procedures came into act because of this only. So this is very important for your exam. So please don't forget these terminologies. Okay, and now let me go to some interesting scans on liver. Some different types of scans on liver we are going to discuss now. So in liver there are 2 important cells. What are they? One is hepatocytes. So hepatocytes, which is doing all the functions of liver, and another is the reticuloendothelial cell of liver is known as what? What is the name of the reticuloendothelial cell of liver? That is known as Kupffer cells. So Kupffer cells is a cell which is reticuloendothelial cell of liver. Another cell is hepatocytes. So let me ask you one physiology question here. What is the function of Ito cells in the liver? Ito cells, also known as stellate cells in the liver. What is its function? Yes, can you tell me? The very important MCQ from physiology. Ito cells or stellate cells produce vitamin A storage. High yield question. Vitamin A storage is done by these cells, but that is not important as a surgeon for me. So I'm not going to discuss about it. Just for MCQ, I'm telling Ito cells or stellate cells store vitamin A. For me, what is important is the hepatocytes and the Kupffer cells, which are reticuloendothelial cells. So please remember, hepatocytes will take up a dye known as hydroxyimmunodiacetic acid dye. So hepatocytes will take up the hydroxyimmunodiacetic acid dye and they will excrete it unchanged. Very important point. Please don't forget this. It will excrete it unchanged without any metabolism. It is excreted in the bile duct into the bowel. It is excreted unchanged into the bile duct into the bowel. On the way, it will be concentrated in the gallbladder as HIDA scan based on hepatocytes. So it should be done only in a functioning hepatocytes. So therefore, HIDA scan can be done only in normal liver, not for a cirrhosis patient or not for a failure of the liver patient. So HIDA scan, the contrast, the hydroxyimmunodiacetic acid is taken by the liver, excreted into the bile duct into the intestine, and we have already discussed it is a gold standard investigation for what? For acute cholecystitis. It is a gold standard investigation for acute cholecystitis. It is a gold standard investigation in which we see non-visualization of gallbladder. There will be non-visualization of gallbladder, and it is also used to look for bile duct leak. It is also to test for physiology of bile flow. Physiology of bile flow is also detected with the help of this HIDA scan. So gold standard to diagnose acute cholecystitis, to look for bile duct leak and to look for physiology of bile flow. All these cases we use HIDA scan. Kupfer's cells. With the help of Kupfer cells, we do a scan known as sulfur colloid scan. So there are two special scans done on the liver. One is HIDA scan, another is sulfur colloid scan. So please don't forget, sulfur colloid scan is based on Kupfer cells, and this scan will show the tumor as hot spot. Will show the tumor as hot spot only in the presence of functioning Kupfer cells. Only in the presence of functioning Kupfer cells, this scan shows the tumor as hot spot. Now tell me, what is the only tumor in the liver which is having normal Kupfer cells? Normal Kupfer cells are seen only in one tumor, that is FNH, focal nodular hyperplasia. Therefore, focal nodular hyperplasia appear as hot spot in sulfur colloid scan. HCC will not have normal Kupfer cell. Hemangioma will not have, adenoma will not have, only FNH will have normal Kupfer cell, and therefore it appears as hot spot. It's a name question. So what is the tumor which is having hot spot, and why is it having hot spot? Because the only tumor which is having normal functioning Kupfer cells is FNH. No other tumor will have normal functioning Kupfer cells. So please don't forget this point in this topic. Okay, FNH as functioning Kupfer cell, and it looks like hot spot. And certain liver function tests we have to know for your exams. Certain liver function tests I want you to know for your exams. They are the following. So the liver function tests are aspartate transaminase and alanine transaminase. So very commonly done LFT, and in this ALT is more specific for liver. ALT. So remember L is there. So it is more liver specific is ALT. So more liver specific is ALT is more liver specific. Please don't forget ALT is more liver specific. And what are the other liver function test means? Alkaline phosphatase. Alkaline phosphatase is an indicator of obstruction of bile duct. So these are all direct one-liners from Sebastian. Obstruction of bile duct will cause increased alkaline phosphatase. Gamma glutamyl transferase is an indicator of alcohol-induced liver damage. Alcohol-induced liver damage will have gamma glutamyl transferase increase. So I'm telling you the importance and significant MCQs from each. Gamma glutamyl transferase is an indicator of alcohol-induced liver damage. And for chronic liver disease, a patient who is having a chronic liver disease, what are all parameters which are altered? Can you tell me? For a patient who is having a chronic liver disease, the parameters altered are albumin. Please don't forget, albumin is a marker. Albumin is a marker of chronic liver disease. Patients will have albumin decreased. And please don't forget, there will be increased prothrombin time and INR in advanced disease. In advanced chronic liver disease, the coagulopathy will be there because of elevated prothrombin time and INR, because of the failure of coagulation factors. So that is also a feature of chronic liver disease. So you have to remember the various points in this chronic liver disease points. So LFT, high yield for exams. LFT, alanine transaminase is elevated, liver specific. AST is elevated in cardiac problems also, so that is not more specific. Alkaline phosphatase is for obstruction of bile duct. Gamma glutamyl transferase is more alcohol specific. And for chronic liver disease, we use albumin. We use albumin for chronic liver disease. Please don't forget these points. So these are the basics in liver, and I want you to know certain scoring systems in the beginning of the liver. Scoring systems in liver. So we have discussed so many scoring systems in pancreas. Similarly, there are so many scoring systems in liver. So let me start with modified child book score. Very important score. Modified child book score. So this is a high yield MCQ topic. You have to memorize the values modified child book score. So the child book score, the values are given as value number 1, 2, or 3 based on 5 factors. I used to remember the factors as BAPI. So bilirubin, ascites, BAPI, albumin, prothrombin time, encephalopathy. So it modified child book score is based on BAPI, bilirubin, ascites, albumin, prothrombin time increase, and encephalopathy. So bilirubin, what is the value of bilirubin? So bilirubin is 1 to 2 milligrams per deciliter. It is 2 to 3 milligrams per deciliter. It is more than 3 milligrams per deciliter. Simple method. So 1 to 2, 2 to 3, more than 3. So we give points 1, 2, 3 for that. So we give 0.1, 0.2, 0.3 for these values. So 1 to 2 milligram, 2 to 3 milligram, and more than 3 milligrams per deciliter. So there is no ascites in 1. There is mild ascites in 2, and there is severe, moderate to severe ascites is 3. Moderate to severe is 3. So albumin, the normal value of albumin is more than 3.5 grams per deciliter is normal. So if it is more than 3.5 grams per deciliter, we say it as 1. If it is 2.8 to 3.5, it is 2. If it is less than 2.8 milligrams per deciliter, it is 3 points are given. So please remember, more than 3.5, 2.8 to 3.5, and less than 2.8 is the value we give for this thing. And prothrombin time increased 1 to 4 seconds. It is increased 4 to 6 seconds. Increased more than 6 seconds. It is known as the prothrombin time elevation. Encephalopathy is absent in 1, and in grade 1 or grade 2 encephalopathy in 2, grade 3 or grade 4 encephalopathy is 3. So please don't forget these values. Sometimes very difficult to remember the values. You have to mug up those values at the time near exams. So very simple. One is normal albumin more than 3.5 grams per deciliter, and prothrombin time is only 1 to 4 second elevated. Only 1 to 4 second elevated. And with all these things we make a count. And what is child A? What is child B? What is child C? Which is the worst child among the 3 child? Which child is very bad and very sick? So child C is very sick child. The score is 10 to 15 points. Child C will have 10 to 15 points. So the modified child book score, the maximum score is 15, minimum score is 5. So 5 to 6 is known as A, and 7 to 9 is known as B. So please don't forget B. So child B is 7 to 9. When the score is 7 to 9, it is child B. 10 to 15 is known as child C. So child C is a very worst child, worst prognosis. Child C is worst child. They have very worst prognosis. So this is one score used to categorize the people with the DCLD, decompensated liver disease with cirrhosis patients. We classify them into child A, child B, child C. In those days, this child book score was used for liver transplantation. Now we are not using this score. The problem is because now when you apply this child book score, there are no fixed values. Sometimes the surgeon will write there is a mild ascites, sometimes they will write no ascites, sometimes the encephalopathy cannot be graded properly. So this is not an accurate value for liver transplantation waiting list. So this is not used now for liver transplant waiting list. Not used for liver transplant purpose. It is only to categorize the DCLD patient into 1, 2 and 3. So now the next scoring is on MELD scoring. MELD score, model for end liver disease score. Model for end liver disease. Model for end liver disease score. Is a MELD score we have to remember for exam. This is the scoring of choice for liver transplant patient waiting list. So previously this score was used after TIPS. First it was actually used for following a TIPS prognosis. But later on it is very nice scoring system that is now used for waiting list of liver transplantation. It is based on 3 values, easy to remember. It is CBI. It is based on 3 values, CBI. It is a logarithmic score of CBI. It is creatinine, bilirubin and INR. It is creatinine, bilirubin and INR. So the value extends from 6 to 40. The value extends from 6 to 40 and we put waiting list for people more than 15. So indication of waiting listing. Indication for wait list. From which number onwards you put wait list means above 15 onwards we put waiting list. So therefore based on the number, for example, a person who is having 40 points will be given the first one to take the organ, and which is having 36 will be second, like that. It is like a waiting list scoring system. So waiting list scoring is based on this MELD scoring. Please don't forget MELD score is an expected MCQ. It is based on logarithmic score of creatinine, bilirubin, INR. It is a fixed value, so no tampering can be done in this. So no tampering can be done, and it extends from 6 to 40 and above 15 is an indication for waiting list. And for pediatric cases there is a new scoring system known as what? That is known as pediatric end liver disease score, PELD score. That is a score known as PELD score for pediatric patients. That is based on BANIA. It is based on BANIA. That is known as BANIA. It is not based on bilirubin. Nothing to remember. Just remember, not ask an exam. Bilirubin, albumin, nutrition, INR and age. So this is based on bilirubin, albumin, nutrition, INR and age. This is known as PELD score. So PELD score is based on BANIA, bilirubin, INR, albumin, nutrition, INR and age. So not much important. Just have this score. So just I'm telling you various scoring systems in liver. I want to tell you one important score which is being nowadays asked in exams. First of all, you should know where it is used. That is known as King's College criteria. Where is it used? Can you tell me where is this scoring used? King's College criteria score. So first of all, tell me where it is used. King's College criteria scoring system is used for a liver transplantation in acute fulminant liver failure. Acute fulminant liver failure. So please remember, in India we have many methods to do suicide. We will eat OPC, we will eat Olean resin, many methods are there. But in Western countries, most of them will have only one method, that is to consume excessive amount of paracetamol, 100 paracetamol. So paracetamol is a on desk, you can go and buy the drugs in the medical shop. So the paracetamol they will consume in 100 numbers. So that will go and cause acute fulminant liver failure. So paracetamol induced acute fulminant liver failure. When will you do liver transplantation? When the pH of the patient, when the pH is more than 7.3, or if the pH is pH is less than 7.3, or if the prothrombin time is increased more than 100 seconds, plus creatinine more than 300 millimoles per liter, 300 micromoles per liter, and grade 3 or 4 encephalopathy. So this is one thing I want you to remember. It is of 2 types of King's College criteria. One is for paracetamol induced liver failure, another is for non-paracetamol induced acute fulminant liver failure. So no need to remember both. At least remember this paracetamol induced liver failure. So when the pH is less than 7.3, or when the prothrombin time increase more than 100 seconds, creatinine more than 300 micromoles per liter, and grade 3, grade 4 encephalopathy is associated. All these 3 are seen. If these 3 are seen, or only pH is less than 7.3, we can take them for liver transplantation. This is known as King's College criteria. So I request you to remember King's College criteria for your exams. So please don't forget King's College criteria. So now let me revise what we have discussed so far. So right hepatic artery, accessory right hepatic artery comes from where? Accessory right hepatic artery comes from superior mesenteric artery. Accessory left hepatic artery comes from left gastric artery. Accessory left hepatic artery comes from left gastric artery. Accessory right hepatic artery comes from superior mesenteric artery. So these are the 8 segments. Please don't forget segment 1. And this is what I told you. Segment 1 is further divided into segment 9 and Spiegel lobe. This is a picture based on Blumgart book. There are 2 segments in segment 9 and segment Spiegel lobe, or the 2 things together make the caudate lobe. So the various types of hepatectomies I told you, please revise it. That terminology is known as Brisbane 2000 terminology. Please don't forget the terminologies. And please remember this picture. It's one time asked question in all India from Sabiston long back. On the undersurface of liver, the glissans capsule of the liver is thickened to form a thick plate, so that thick plate helps for attachment of gallbladder, attachment of falciparum ligament, entry of all the structures. So what are the plates? The gallbladder attached to a cystic plate, falciparum ligament attached to a umbilical plate, the hilum has a hilar plate. So the plates seen on the undersurface of liver are, or on the inferior surface of liver are cystic plate, umbilical plate, hilar plate. So this is a question asked one time in all India, so I am discussing this. Just remember the plates on the undersurface of liver. And this is the picture I told you for HIDA scan. You can see the scan. The contrast is taken by the liver. It is going to the gallbladder, and from gallbladder is getting more concentrated. It is excreting into the bowel. HIDA scan. So this is a sulfur colloid scan. You can see the hot spot. Which tumor appears as hot spot? It is FNH. So please don't forget modified child book score. Please remember grade B. Grade B is between 2 odd numbers, 7 to 9. So A is less than 7 and C is more than 9. So remember like that. Between 2 odd numbers is grade B, 7 to 9. And CBI is for MELD score. So the score value ranges from 6 to 40, and we put the waiting list above 15, and this is based on Sabiston page number 658. Please follow this point. Okay, there is so many controversy in this. Don't follow anything else except following the Sabiston. And this is bilirubin, albumin, nutrition, INR, age score for pediatric known as BANIA. And I told you King's College liver transplant score for acute fulminant liver failure. Please remember only for paracetamol pH is less than 7.3, or prothrombin time more than 100 seconds with the serum creatinine above 300 micromoles and grade 3, 4 encephalopathy. So this is not needed for PG level. If you are giving the notes, if super specialty level, this can be remembered, but not asked in PG level so far. So remember for paracetamol induced acute fulminant liver failure. So I have told you gamma glutamine transferase is for alcohol related liver disease. Albumin is a marker of chronic liver disease. Please don't forget albumin is a marker of chronic liver disease. Okay. So and these are the points in the introduction of liver. So these points are the introduction of liver.